This is a video entitled Going Around the Clockface, Third Time Pyloric Disruption with Redo per Oral Pyloromyotomy. The authors have no disclosures pertinent to this video. The subject of this video is a 58-year-old female with long-standing gastroparesis. Her additional medical history includes sarcoidosis and colonic dysmotility, for which she had already undergone a total abdominal colectomy. Additional surgical history included hysterectomy and cholecystectomy. To detail her gastroparesis history, she had undergone multiple attempts at solid-phase gastric emptying after long-standing symptoms of delayed gastric emptying, but was unable to finish this at any point due to vomiting the meal. She had undergone endoscopies numerous times with retained food and clinically was thus diagnosed with gastroparesis. Over the course of several years, she had had multiple balloon dilations of the pylorus, which always followed with 2 weeks to 2 months of symptomatic improvement. She then moved on to botulinum toxin injections of the pylorus, again with symptomatic improvement, but these were becoming less and less effective as time went on. As her gastroparesis symptoms became less well controlled with minimally invasive operations, she was referred for surgical care. She'd undergone 2 prior surgical interventions for gastroparesis. The first, a peroral pyloromyotomy, performed around the lesser curve. This was completed 16 months prior to the operation that is detailed in this video. A gastric emptying study was successfully completed following that operation, which was consistent with moderate gastroparesis. Given recurrence roughly 4 months later, she subsequently underwent a laparoscopic pyloroplasty and a gastric electrical stimulator that was successfully placed. Again, a gastric emptying study was completed, this time showing mild gastroparesis. To give you an idea about how these prior pyloric disruptions impacted the pylorus, the first, the pop, was anterior, about 12 o'clock on a clock face, and the second, about 9 o'clock on a clock face when viewing the pylorus. The patient was resistant to undergo a resection for gastroparesis and was offered a third-time pyloric disruption, this time to be a peroral pyloromyotomy performed along the greater curve, placing it at 6 o'clock on the clock face. The patient was brought to the endoscopy suite and underwent general anesthesia with endotracheal intubation, as is the protocol for all patients undergoing peroral pyloromyotomy. A diagnostic upper endoscopy was performed. We encountered food both in the esophagus and in the stomach, which was cleared prior to proceeding with the operation. The initial step in this case was to use a impedance planimetry device to measure the distensibility of the pylorus. This would give us a good idea about how the pylorus might improve after the procedure. The waist seen in the diagram corresponds to the pylorus, which is minimally distensible compared to the surrounding tissue. We begin the pyloromyotomy by creating a submucosal cushion using a commercially available injection agent that's approved to expand the submucosal space for tunneling. Once a large cushion is raised, a triangular tip knife is then used to make a transverse mucosotomy along the greater curve. And this orientation is oriented at 9 o'clock on the clock face. Once the transverse mucosotomy is completed, the loose areolar fibers that are tethering the mucosa are released, and the mucosa is then able to be lifted and the scope engaged into the submucosal plane. Also note that a transparent silicone cap has been fitted to the endoscope, which was not present during the application of the impedance planimetry because it impedes with the device measurements. A tunnel is then developed underneath the submucosa with the goal of identifying the pyloric muscle. The pyloric muscle typically appears as a glistening white ring that is visible here in the background. Likely due to the extensive prior interventions on the pylorus, including surgical and submucosal tunneling techniques, as well as numerous botulinum toxin injections, there is a large amount of scar present in this tunnel. Typically, this release is accomplished much more easily, and you can see the degree of difficulty that occurs when this is a multiply redone pyloric intervention. Once the loose areolar tissue has been separated and the pyloric ring has been well visualized, we begin to divide the muscular component of the pyloric ring. Note the difference in the char pattern here compared to the earlier steps. This is because the muscle tends to char more than the submucosal space. This is the completed pyloromyotomy. Also note there is a hole that is into the duodenum. This was later clipped to close this full thickness injury. The transverse mucosotomy is then closed using a number of endoscopic clips. We typically begin this closure by firing clips at both of the corners, because this tends to bring the other edges of the mucosa together and make all subsequent clips far easier to apply. In this case, we used a total of 6 clips to completely close the mucosotomy. The procedure took a total of 55 minutes. There was no blood loss with the exception of the small amount you saw on the screen. There was no specimens collected, and the intraoperative complications were none. The time of the operation included both measurements with the impedance planimetry device as well. The patient was discharged home the same day, and as is customary at our institution, with a 2-week supply of proton pump inhibitor and Carafate to ensure that the mucosal flap heals well. At initial follow-up, her symptoms were improved, and we are still awaiting a repeat gastric emptying study to be performed at a later date. There are several key takeaways from this video. First, this is the first to our knowledge to report a third-time pyloric disruption, particularly after both peroral pyloromyotomy and pyloroplasty. This additionally demonstrates that repeated pyloric intervention is not only technically feasible, but may improve gastroparesis symptoms. The idea of repeat pyloric intervention is predicated on the idea of organ preservation, in this case, the stomach. This is particularly useful in a patient such as this, who is on the one hand resistant to have a major gastric resection, and on the other is high risk because of her prior intestinal resections for other causes. While our current algorithm does point toward the need for gastrectomy for patients that fail minimally invasive therapies, repeated pyloric disruptions may delay this inevitability. And finally, when planning a repeat intervention that may involve cutting the pyloric muscle, it should be planned such that the anatomic location does not overlap with prior interventions.